Okay, just while we're admitting a few more people, at the bottom of the screen, you'll see the chat box there, little chat bubble. If you have questions as we go through, please put your questions in there, and the team here will monitor those and help make sure that I don't miss them. We'll answer as many as we can today, and then we'll get back to others, and there may be, if there are complicated ones or multifaceted ones, we may end up sending you an email to respond to those as well. Thank you for being here. For those that haven't met me in person before, I'm Gillian Robinson, founder of Healthcare Compliance Solutions, registered nurse and auditor, and the designer of the software that you use within the HCSL system. So I thought it was a good opportunity, or I and the team thought it was a good opportunity to bring you together just to talk about a range of things that are happening at the moment, that might be happening for you, that relate to how you use HCSL or how you prepare for audit. So Mark Sadler, if some of you can see Mark Sadler's name on the screen there waving at you, for those that you can see Mark.
Hello, everyone.
Mark is our business partnership manager. He's in the team here with us. And we also have Carolyn. Give us a wave, Carolyn. There she is. And Rachel, you need to swing this way. Rachel's beside me. There we go. There's Rachel. So, okay. So for the sake of transparency, this session is being recorded. It's being recorded so that we can share it with other HCSL clients that aren't able to join us today, that have asked if we can please do that. So if you're not happy being recorded, then probably turn your camera off, and that's fine, and stay silent, and you can just observe quietly in the background. Otherwise, we'll get into it. So welcome, everybody. Thank you once again for being here. I acknowledge that in current times with COVID and outbreaks, and in particular staffing shortages, which are extreme throughout the whole country, it's a real struggle for many of you, so to find time to do extra things. So just acknowledge that. So firstly, audit prep. I know in some regions the DHBs have advocated on ARC's behalf and have managed to get audits stopped in regions at the moment while these outbreaks are still underway. I believe Canterbury is one of those regions, but certainly that's not the case nationally. There are audits going on in other parts of the country. So firstly, when I'm talking about audits, if you're aware that you have a pending audit, please let us know. Please send an email to support@agedcarecompliance.com, and one of the team will see that email come up. So if you have an audit pending, please just flick us an email so we can make a note of that. I have been going through the policies and procedures and updating them to comply with the Ngāpurewa Health and Disability Standards, Services Standard, the new standard that you will be audited against. So we're still in a grace period, and that grace period was 6 to 12 months for partially new and 12 to 18 months for totally new criteria from the 28th of February this year. So we're into that grace period where if you have an audit at this point in time, it will be about against the new standards, but you won't get any findings in relation to those new standards. They will make recommendations, they will make comments, they being the auditors. And so please, when you get those, forward them through to me. The documentation review gets done by the auditors online. You don't need to send them any policies and procedures. So just remember that there is an auditing schedule for the Schedule 1 that they send in your facility documents area. So that's already filled out and completed for you to support you with that audit process. So as I say, any queries around audit, please do get in touch with us so that we can help make that as seamless as possible for you all. All right, so clinical governance, what are they looking for in these new audits? What are the key hot topics that they're looking for? All of the usual stuff, all of the follow on from corrective actions in your meetings and your infections and your analysis and all those sorts of things. What they're also looking for is information on clinical governance. Clinical governance is a new issue that's been brought up and quite clearly stated within the new standards. And so we have updated the policy. CS space 14 is the clinical governance policy that most of you should have been supplied by now. We have been working through sending a number of updates and uploading those into your systems. So the clinical governance document will be there. All right, and that's supported by the other CS14 range of documents. So have a look at that. Make sure you get back to me if you've got any queries or questions or something in there that doesn't seem to make any sense. All right, and we can go through and have that discussion and get clear on that. So the next key thing, and this is the overarching concept at the moment that is causing some hiccups for people to understand the implementation, is the Maori cultural aspect and Pacific peoples aspect of implementation into the service. So we've been updating policies and procedures. In the past, we've had one integrated document that had, well, we had two, one for spirituality, and we had a separate document that was the Maori Health and Ethnicity Awareness Plan. So the audit agencies, even though the standard doesn't say it, the audit agencies have made it quite clear that they expect to see separate documents. So I have gone through and I've put the Maori Health Plan together as a separate document. I'm working through the Pacific Peoples one at the moment. And of course, I can't just do this off the top of my head. I need to consult with other people. And I have been consulting with a kaumātua in Christchurch, lovely lady who is a kaumātua in the Methodist Church here. She's also on a number of other boards. And so she's been supporting and helping with that update process. So we'll continue to work through those, and that's why I say if you've got a pending audit or a notification of a pending audit, please let us know so that we can make sure that you've got those updates provided for you. Ethnicity and reporting, ethnicity tracking and ethnicity and reporting is the next key thing that they're looking for. So we have made some changes to the documents. One of them is HR space 6. HR 6, that's the employment application form. We've added ethnicity to that so that when you are interviewing potential recruits, hopefully you're getting some applicants, that you are tracking their ethnicity because you need to be able to report that through. I've got somebody in the waiting room there. No? Okay. You also need to be able to report ethnicity, not just of your residents, but not just your staff, but also your residents. And that is already tracked in the resident details. You'll see there that you can select that, or if there's not something that fits the resident's identification as they self-identify, then there is a free text field that you can write that in. Or also you can write the iwi and the hapu in there as well. So in your reporting, in your adverse event reporting, your trend and pattern analysis, so under the monthly summary, there's some fields that you write in. So you've got your data, and then there's some fields, free text fields that have got some prompts on and you write in. I think the second box down is the one that talks about trends and patterns. So that's where I would ask you at this point in time to please be writing in your ethnicity breakdown of the data that relates to that particular month so that you're showing that.
Sorry, Gillian.
Yes.
Sorry. Whereabouts are you? I'm in the trends, the adverse events trends. Where are you saying to put that ethnicity?
If you go into the box, the second box down under the graph, so if you're in your adverse event analysis,
yeah,
and then you go into summary, if you scroll down a little bit beyond the initial data.
Yeah, here it is. Yep, I've got it. Okay, cool. Thank you.
Okay. So you'll see that there, all right?
Yeah.
So somebody's asked if I can just reiterate those time frames For the grace periods, once again, the grace periods are for 6 to 12 months for the partially new criteria starting from the 28th of February, so that's through to the end of August. All right, 6 to 12 months, that's your 6 months. 12 months is obviously through to the end of next February. So we've got that leeway to give us time to update policies and procedures and make sure that we're on track there. For the completely new criteria, and there's about 20 of those, the grace period is 12 to 18 months. So you've got longer before the audit agencies or the auditors can make a finding against you in that area. All right, so once again, tracking ethnicity, reporting that, putting it in your analysis there somewhere. You must evidence your contact with Kaumatua or your key point of contact with your local marae or your local Maori advisor so that that is quite evident. I spoke to an auditor just recently and they'd been on site doing an audit. They were about to tick off the audit and say, yes, this is completed because it had the point of contact, and they noted that in the policy and procedure. That was their local regional contact for Maori advice. And the auditor, just as she was about to tick that box, as it were, said, so you have actually made contact. This is a person you've had an interaction, a personal interaction with. And the provider said, well, no, but that's the person we would go to. And then, of course, the tick became across. So they do want you to actually have made contact and make sure that you are starting to form. This is about relationships, so that you have that integration in a relationship so that you can then nurture that and grow on it as time progresses. Okay, so just a wee hint and tip there around that. I've mentioned already the policy splitting into the different categories, and I'm continuing to work on that process. Restraints and enablers, that's the next thing I wanted to comment on. And certainly when it comes to these new standards, they don't talk about enablers anymore. Enablers were a form of restraint, because they did limit the normal function of a person, or they restricted a person in some way, therefore they came under the definition of a restraint. They're not being classed as enablers anymore. Anything that restricts the physical ability of a person or their choice to move in a way that they would normally choose to do, so restricts their freedom of movement, is a restraint. And it doesn't matter who has authorized that, whether it's the person themselves or it's a nursing family whānau collective decision if the resident isn't able to consent for themselves. Either way, it's a restraint. So what I would like you to do, I've had a quick look at some of the registers, the restraint registers online, and I see that we've still got quite a lot of them are noted as enablers. As I say, with those grace periods, you've got some time as you're going through those reviews for your restraint reviews to make sure that you go through and have a look at those on the list that you've had as enablers, and just check, is it still meeting the definition of a restraint? Is it still something that you need to have in place for safety for the resident that is going to restrict them in some way? All right. Just another question that's popped up here. How would you categorise if a resident themselves requests side rails? Once again, it depends on whether that limits their function, limits their ability to move and get out of bed or do what they would normally choose to do. If it does limit them because they can't put those bed rails down, then that is a restraint. For the moment in time that they are in that situation and they can't do what they want to do and they have to wait for you to come and put those down, that's a restraint. Okay, so those that have been classed as bed rails before, bed rail enablers before, for example, may now need to be changed to restraint. So I would suggest that with doing the next review that you include that into the process. Okay, another question here, is there any way we can delete a document that has incorrectly been uploaded into the wrong residence file? Yes, there is. You email us at this point in time. Because of the legality of clinical data and clinical documentation, you shouldn't actually be able to pull information in and out and change it. Just like you wouldn't tear a page out of a hard copy book that was a clinical record. These are legal documents and we need to apply the same set of rules. So in that instance, you would send an email through that forms the paper trail and describe what it is that's been put in the wrong place. You would put it in where it belongs, so it is in the right place. Make sure things are correctly labelled. And I suggest that in the policy there is some prompters on how to label documents to help you get them, make sure that they do get in the right place. All right. When you send that request through, we can take that out for you, but we do keep a record of the communication that's requested it, and we will respond to you saying that we have taken it out as per your request. Okay, it looks like we're getting a few questions through about restraint, and I'm just wondering if it may be a good idea to do a separate webinar on another day to actually focus on restraint as a separate topic. If that would be helpful, can you write yes in the chat box, please? And we can do that. Okay, yep, we're getting a series of yeses. Yes, 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 yes. Okay, great, all right. Mark's in the other office and I can see you watching there. So Mark, can you please just note down, and we'll organise another webinar on another day to break down and talk about restraints as they are in the new standards. Okay, so we'll have a Q&A session at the end, just for those things that I'm not touching on or that I've gone past and you have questions. So note those questions down either in the chat box or on your piece of paper, and we can go over those at the end. Adverse events are the next area or topic that I just wanted to touch on. Remembering that in your adverse event, when you're logging them on, there is a level of event. Now, that level of event relates to the level of risk that the event is. Beside the level of event, when you go into the online system to log that, you will find next to that field a little blue question mark. Run your mouse over that little blue question mark and it will come up with a list of definitions to show you what the different levels are. Now, it's important that we're using that consistently to get a consistent classification of those events, because this is what your benchmarking is reliant on. If those are not correct, then your benchmarking is not going to be correct either. All right. Every so often I see one come through and I send an email through saying, I just had a quick look and I don't think that person actually died. A level 1 is a severe, so that's a sudden death as a result of an adverse event, not being a medical event, but being more of a health and safety, an adverse event being a fall, something like that. So a level 1 is a sudden death as a result. Okay, now I saw one come up recently that was classed as a level 1, but it was actually 2 staff having an altercation. So I don't think anyone died in that altercation, regardless of what the intent may have been. All right, but please just double check before you sign off and close off on those adverse events to make sure that they are correct for the level of risk. They align with those levels of risk align with the Health Quality Safety Commission SAC scores, just in case you weren't aware of that. So also making sure that before you close off those events that you add in an investigation and the corrective action. All right, don't just leave those boxes empty. They're not there just for decoration. They're there to help make sure that when the auditors come on site, they can see quite clearly that you've closed the loop on your adverse event, that you've done the investigation. And the investigation is identifying what could have possibly contributed to it. If you're not quite sure, go back to the adverse event policy and have a look at that, where it gives you a description and talks you through a flow chart of how to do the investigation and who should be involved in investigations at different levels of risk. All right, making sure that we're using people's time appropriately. So I've already mentioned making sure that we are including ethnicity reporting within the end of month summary. All right, so that's adverse events. The same sort of thing applies to infections, making sure that you are using those definitions that are in the system. They relate to the McGreer's definitions of infections, so the international groupings there. The next thing that I wanted to talk about, and I'm racing through this pretty quickly, but the next thing I wanted to talk about was, these are the things that come up as frequently asked questions. So I've asked the team and I said, what are those things that we keep getting queries about that people want to know or they seem to get caught up on? So clinical assessments, I'm just looking down at my pad here. Clinical assessments is one of them. And making sure that you're not duplicating. If you're doing an assessment within the software, you don't need to duplicate that by doing it on a piece of paper as well. All right. If you feel that you're doing the same thing in two different places, one of them you should be doing. Okay. So with the clinical assessments also, when it relates to the Coombs assessment.
What caught my eye was the car in the car park's got no more lies and all this stuff. Oh. And then Michelle, lovely Michelle, comes in and lunch with me.
Can somebody mute there? I can't see.
That's a meeting, thank.
It's Annette.
Okay, I've just muted. Annette, I've just muted you because we could hear the conversation in the background. All right. But you can unmute yourself later if you want to ask a question at the end of the session. And if there are questions that you didn't get up, please, just a reminder, you can send those through on email to support@agedcarecompliance.com. All right. So there's a couple of assessments that we've had in the system that are actually within the Inter-I, but they're named differently. Now, I've had this confirmed with the Inter-I team in the last week that the Coombs assessment doubles up as the fracture risk scale. So if you're doing your fracture risk scale within Inter-I, you don't need to also do your Coombs assessment. Within the initial care plan, the ICP online, you'll see that there are fields built into there that are assessment fields. Those are sufficient generally to start for your first 24 hours and start that initial care planning process. The assessment information that's necessary is built into the software. Generally, you don't need to do other assessments as per the Coombs, and the other one is the Braden scale. The Braden scale is actually replicated by the pressure ulcer risk scale within Inter-I. All right. So if you're doing either the Coombs or Braden, we will make sure, I haven't had a chance yet to update the policy around that, but I will update the policy to make that very clear so that you're not doing unnecessary duplication, because I know the one thing that you haven't got, especially the nurses, haven't got more time. The next common question we get around clinical indicators and where to score information or put information is about the bowels recording. So we've got a number of options. The first one, thinking about those of you that have the integration with Medimap, and if you've got Medimap but you haven't got the integration active, so that it's not already giving a flow of information coming from Medimap directly into the HCSL resident file. It happens when there's a PRN medication. It also happens when there is a change in the medication order. So, and later on with the change of the platform that Medimap are working through at the moment, which is fantastic because it's going to give us a few more options to be able to pull some other information through. And some of you may be aware that we actually share an office with Greg and Julie and the team at Medimap. So we enjoy those conversations and thinking about what we can do and how we can streamline things for you. So the first point of call is if you're putting your clinical indicators in, I suggest that you put them into Medimap under the More function in the resident file there, because it has these beautiful graphs and charts and things there. So for recording, that would be the first option. If you don't want to do that, or you're not able to do that because you're using one chart and it doesn't have that ability, then you've got two other options. One, you can put it in the progress notes. Because the filtering system on the progress notes allows you to pick out keywords, you can put in things like BNO day 1, BNO day 2, BNO day 3. Now, if I come along on day 7 and just put the word 3 in the keyword search, it's going to get rid of all the other progress notes and just show me those that have got 3 in the text that's been written into the progress note. The third option is for you to actually use the chart. There is a bell chart in the system and the facility documents so that you can fill out, if you want to, the paper-based, if you want to go back to paper, you can fill out that chart at the end of the month. You can scan that in and upload it into the resident file through that edit profile document upload. So those are the key options that we would suggest at this point in time that you use for recording your bowels. Not your bowels, the resident's bowels. Okay, we'll leave your bowels out of it. Diversional therapy. Now, that's the next frequently asked question. Where do we record diversional therapy? Notes. So the attendance register is still what we've discovered with most sites is the most efficient thing still is to use that paper attendance register. You can once again write it into the progress notes as long as you're using consistent terminology. Then you would be able to use the keyword filter to search for content there. Otherwise, you can use the paper register, which is in the system. It is in the system in an editable format so that you can download it and you can change the content in that actual register to reflect what happens on your site and those seasonal changes that happen from time to time. So that's the attendance register. The diversional therapy care plan, you don't need to have the diversional therapy paper-based care plan. It's incorporated into the initial care plan and into the long-term care plan. Look at tab 10 on the long-term care plan and you'll find it within there. Okay, there are videos. If you go into the facility documents, just a reminder, and put the keyword search video, there are a raft of little 5-minute videos or average about 5 minutes that describe how to use each of these functions. And there is one there specific to diversional therapy. So the evaluation for diversional therapy can also be done directly into the software, into that care plan tab. All right, so you would also do your diversional therapy evaluations there. Okay, so new features. We've got a lot going on. There's a lot going on behind the scenes with planning. There's some features that we've uploaded recently around occupancy, around differences in how you can compare your adverse events month to month and things like that. We are making some further final changes at this point in time to the occupancy bed reporting, so that instead of reporting once a month and giving you that capture, it's going to be able to do it on a daily basis, because we understand that that's important for your invoicing and to make sure that you're not missing out on money there. The resident movement report will show where there has been, so at the left of the screen under residents, you'll see residents reports. The resident movement report is where you will see it may have 2 lines for the same resident. That's because they've changed level of care during the month. All right, and you'll be able to track that and see that in the system. As I say, the reporting will become more defined because it will give you the option of choosing a day and being able to look at that in live time. So that's one of the key features that we've changed recently. Now, I'm just going to share my screen with you if I can. Let me just see how I do this. So this is the piece of work that we're working on, and we expect it to be deployed into at least the testing system and hopefully the live system for you by the end of next week. So this is under the user area. So in the user area, you won't just have the login details as you've had previously. You'll have information about appraisals. You'll be able to upload documents, and you'll have user details. You'll be able to see here there's a competency, there's a completed date, and there's a review date. And the reason we put the review date is the system is going to send you an email notification to remind you when it's next due. Okay, so it's up to you to determine those dates, and the system will help keep you on track by sending that notification. Now, this is, I'm just scrolling down here through some screenshots to give you a bit of an overview of what this is going to look like, or a little bit of what it's going to look like. So we've got the person here, and we can see at an individual level what's happening with that person when it's next due. And then on that next screen down, or at the bottom there, user competencies, we've got that there, and you'll be able to print out or export a report to track those and show what they're like. So this can become, in effect, an online personnel file, because if you have a look in the user details, so we've got their login details first, as they are now. The next tab that you'll see, and these are 3 new tabs being added, is employment commencement date and when they completed. Ethnicity, because as we said already before, the ethnicity of staff needs to be tracked as well as residents. So we have added fields in here for iwi reporting as well. Date of birth, employment type, and you've got some click down options there, or some others for those of you that are really creative and come up with something new and wonderful. Employment changes, and there are free text fields there. So goodness me, you've got 65,000 characters worth of writing there that you can run amok with and write whatever story you like. So you've got plenty of option there to free text write as well. Orientation completed date, vaccination, health details you can write in there, and visa review date is also in there. So the contact details and the emergency contact details for that staff member can also be noted online. And you can upload their documents. So you'll have a range of appraisal, different types of appraisals that you can track in the system, and we've put quite a number in there. I don't have a screenshot of those for you today, unfortunately, but you can see here that, like the resident documents, you've got employee or staff member document areas that come under different classifications as well. So you'll be able to upload documents into that area. So I just wanted to take the time to have the opportunity just to share that with you today. So I'm just looking at the chat box there. There are a few questions about ethnicity. All right, so let me have a look here. I'll stop sharing the screen. All right, we're all back, folks. You can see the standard screen. All right, will HCSL consider having a bell tick box in the notes for the care staff? Medimap is generally used by RNs, so a 2-step process. I know a number of sites have logins for the healthcare assistants, because those are the ones that are actually administering and applying topicals and things like that. So at this point, we don't plan to have a separate field, remembering that each of these things we do, the unfortunate thing with software is it's really expensive, very expensive. the user component, just for an example, the user component that I've just showed you is over $20,000 of funding that goes in to add those sorts of features. So even a small change of a field is very expensive. So where we've got alternative options, we don't tend to add something in. Where we don't have those other things and it's something that everybody's asking for, then we tend to prioritize and have a look at that and say, okay, what are the options here? What can we best do and how can we streamline things? So that's where, as I say, with the platform going forward with the Medimap changes. Did I see Greg come on? Greg, if you're there, can you unmute yourself? I'm just looking through the list there. No. I know that he was tied up with meetings and things this afternoon and was hoping to join us. But I can certainly raise that. But my understanding is with the change of the Medimap platform that is pending for later this year, we'll be able to have the option of pulling through and choosing which data and which information we would like to share within HCSL. So we will continue to have a look at that and keep Bell's forefront of mind for that. So hopefully that answers that question. Are the graphs going to pull over from Medimap eventually? As I say, yes, I'm hoping that that is part of the integration platform process. And the thing remembering is that the two are linked. So even though they're in Medimap, because the two files and the two pieces of software are integrated from a health record standards perspective, you can say that they are integrated records. So I'm just going to scroll back up to see what I've missed there. Love the employee function, was going to ask about that. Fantastic, that's good. Excellent, re-adding appraisals and competencies. Been looking for this type of system for a few years. Well, that's good to hear. Thank you for that feedback. It's nice to know because that's what we want to do. We want to make sure that what we're doing is meaningful for you and that it's actually going to help you streamline and have as much as you can of everything you need in one place. So, as I say, my intent and my hope and my communication with the IT team is that we will have that for you by the end of next week. Like everybody else, the IT team have been afflicted with COVID and staff in isolation and various things. So timeframes and work schedules have been thrown a little bit because of that. The other features that we're adding after that relate to financial fields, and there'll be a raft of financial information, financial fields that will be put into the system to help with the invoicing. So there'll be a new tab in the resident profile that relates to finances. It will have security around it because it's there will be information in there that not everybody needs to be aware of and should be looking at. So there'll be some extra layers of security built around that particular tab for that reason. With the user, just going back a step, with the user information, there will also be a new HR role definition for that so that you on site can assign that definition to who you want to manage your HR records. Because once again, there is private addresses there, there's phone numbers, there's private information. And so for privacy and security purposes, we would want you to be managing that at your end. That's not something that we need to do. I'm just looking back at the chat box here. Medimap integration, HCSL records when a PRN is given, but not when it's evaluated. Can this be added? Once again, we'll make a note of that. I think a number of other people have asked for that. The effectiveness of the PRN, for example, is that what you're meaning? I'm taking it that that's what you're meaning. A number of people have asked for that information to be pulled through as well. So when that platform's available and we're able to pull extra information, we'll make sure that that's at the top of the list for you. How do we see what staff have accessed in the policies? For auditing purposes, if you go to the left-hand side of your screen and look at the admin function, under admin, there is document access, what's it called, Mark? Document access auditing. And when you click
that's
on,
the one.
Yeah, thank you. When you click on that, it will take you to another table that shows you exactly what documents have been accessed. There's a search field in the top right-hand corner of that screen. If you put either a word from a document or the name of a staff member, it will reduce that list to show you the result of that search. So you can then get a report of all the policies and procedures and the videos, for example, that a particular staff member has looked at. You could then save that as a PDF. Let's not print out stuff and waste the forests and the ink and all the rest of it if we don't have to. So you could save that report as a PDF, and then once the users are ready at the end of next week, you can then start uploading it into that user file so that you keep that information there.
Gillian, there's a question a bit further back from Grace regarding ethnicity. I'm not sure if you've covered that off, just about responsibility on the data.
Let me just, taking into account how we will be reporting ethnicity data in the adverse event, is it our responsibility to do any follow-up on the ethnicity data, or is this purely for data collection? The auditors will be looking for it within your adverse event summary reports. So they will be looking to see that you are including it. It is a requirement of the new standards. I didn't think it was, to be honest. I thought that we just had to report the ethnicity of staff to show that we had a diverse workforce, that we were working on the basis of diversity and inclusiveness and equity. And I thought that that was the same reason we were collecting ethnicity data in relation to residents. But when I looked at the standards more carefully, I did see that it actually does say that it must be ethnicity reporting in relation to data as well. So that's why I'm saying there, the auditors will look for it within your internal adverse event summary data reporting for your trends and patterns. You probably will be expected also, I would imagine, to follow that through, so that reporting is going through into your governance reports. There's certainly more emphasis on reporting through to governance level, and governance level having a commitment for various things. One of those is making sure that you do have a diverse and inclusive workforce that represents equity, that you also have an absolute commitment to no restraint use. So those are items that would be on your governance, your management meeting reports or meeting minutes going forward. Hopefully that covers that question. I'm just going back a little bit further. Yes, those were all in relation to restraint. What is the document, how to label documents? So I'm pretty sure that's within the documentation report writing policy, the CS space 14A. If it's not, Mark, can you just make a note, or Carolyn, would you make a note, please? Just to make sure that that's where it is, and we'll get back to Rachel with that question if it's a different answer. But I'm pretty sure that within, it's a long document, that particular document. Are lap belts on electric wheelchairs for residents who are cognitively aware considered restraints? It depends on their ability to manage that, and as I say, I'll cover that off within the restraint session, but think about their independence and their ability to self-manage that, or is it something that for a moment in time, no matter how long, is going to stop them doing what they would choose to do. Okay, how would you categorise if residents themselves? Yeah, that's the same sort of thing. Okay, I think we've covered off the other questions that I see there. There's some new questions popping up down the bottom, so I'll go back down there. Can we only see one name at a time? No, and this is in the document access auditing area. It shows you all of them. So you can see all of them together, and then you can break it down per document or per resident. So you can break that down further. Somebody just saying that they have to go and thanking us for the session. That's absolutely fine. In the absence of being able to keep in touch in person, and I have started some of those visits again, and I'm heading up to Blenheim. I can see you there, Naomi. Yay! I'm going to head up to see the team, a couple of facilities in Blenheim in the next couple of days, and we'll be visiting Auckland later in the month to see some providers up there as well, which I'm looking forward to. It's always nice to get in the same room and have that personal conversation. Another question here for our internal audits: do we continue using the current version? Will there be a more sort of Nadia app? No more sort of Nadia app at the moment. We tried the Nadia app thinking it was going to be a good solution for you, and it actually ended up being not a good solution. So we pulled back and we're using the original because it had everything in that we needed, and it worked and it did its job. I am working with another project at the moment where we are looking at what can we do differently. Is there something else we can do to streamline that further? If we do, it will probably still be a link where you go into another piece of add-on software. But yes, at the moment, please do continue doing your internal audits online through that extra internal audit tab. Would there be any options for adverse events? The information to be pulled on ethnicity could be pulled from the resident report. Because sometimes there's free text fields as well as the tick boxes, unfortunately, these things aren't as easy as we would like them to be. And so at this point in time, that's actually an incredibly expensive exercise to do, unfortunately. And my hope is, when I've looked at it and I've done some trials, what I did find was the majority of the residents showed up on the resident list there as being New Zealand Pakeha or New Zealand European. There were only a few that were other ethnicity groups. So the number of people that you're having to track that through manually would be very small. All right, so that's give me some feedback on that as we go through the next few months, and let me know what you're finding there. But from the tests and the trials that I did, that's what it showed. Would like another session on non-clinical policies? Yep, absolutely, that's fine. And for a few people that have said hello there, hello to you too. It's really nice, as I say, to be able to connect at least like this. The communication on the admin notice board doesn't allow for communication for specific individuals. Is this possible? At this point, it's role-based, so you can define it down to a specific role, but it's not individual user-based. That may be something that we could possibly look at in the future, but it's not been something that's been asked for by more than yourself, actually, at this point in time, for the person that asked that question. So we'll keep an eye on that and see what feedback we get. Sent through a request to cover what is expected of staff training. Okay, yes, the staff training requirements have increased, and what I suggest to you, we will update a schedule, a training schedule, and what I suggest is that you look at, are you covering off those topics within orientation? Are you already covering them off within the self-learning packages that we provide? And I think for a number of those things you are. Can you combine topics? And I think, yes, you can. Are there a number of online topics that you can access? Yes, there are. And in the end of the training policy, the update for the training policy, we have given a number of different links to different sites that you can do online training, so that helps manage that, because I used to go on site and do training sessions. I don't do it anymore, and the key reason being that actually the number of people that needed to be in and out of the room and couldn't be there for that period of time because of staffing shortages just made it non-effective. So having those online options and looking at quizzes and many things where you work with your team like that is probably, I think, more where we're going to be going in the future. There are programs like Altura, which is an online learning program, and I know a number of you already use that, and I've seen that, and it seems to be very good. It is customised to New Zealand. So there, as I say, with the HR 29, the training policy, with the update for that, we have added in a number of links for options there. Deceased, discharged, deactivated residents in HCSL, how long do they stay in the HCSL? They stay in there the same period of time that you would be required to archive a record under the health record standards, which is 10 years from the date of the last entry. So we host and we store that data for that period of time. Okay, we become your online archive for your record as well, so that you're not having to print off those files and have them sitting there for that period of time. It does stay. You can, on a number of the logs, you can tick a wee box at the top, sort of right generally, that says only show active files, so that you're just looking at the active resident list rather than everybody. And others have said they need to head off. So thank you for that. Query from a facility. Why do we need different logins for different facilities? The simple answer is you don't. If you have a GP, and we have the situation with a number of GPs, and certainly in Dunedin, for example, with nurse practitioners there that are overseeing multiple sites, they have a primary login, and we can link the sites that have given permission for them to access them through that one login, and they can toggle between those sites. So at the top, when you log in, you'll see your name at the top. We can change that so that we can add multiple facilities into one login. So if you've got an off-site general manager, or for multiple sites, or a GP or nurse practitioner, as I say, that's looking at multiple sites, we can do that. Each site would need to give their permission, and then we can do that for you. So can the save option on the adverse events be before we identify level of event and treatment given? We expect HCAs to commence forms and then completed by RNs. However, it's not appropriate for HCAs to be filling these areas, and the RNs can't always follow on immediately. That's fine. A couple of things there. One, don't be in a hurry to close it off, because even if they've noted it as a level 1 and you're the person that's following through, you can change that to a level 3, level 4, level 5. Okay, so you have the ability to change that and correct it before you close it off, and that's important that you do that. That's part of your closing off process, is making sure that that level is accurate. The other thing is, if there are boxes that are compulsory and those little red asterisks show the compulsory fields, if they don't know what the treatment is, they can simply write to be confirmed or to be added. The computer can't read. It doesn't care what you put in the box. It just wants something in the box. All right, so in that instance, you can just write something like that in there, TBC, so to be confirmed. And then the person, once again, following up, can go in, the registered nurse can go in and add the detail and put what needs to be in there. So hopefully that answers that question. Any chance of filtering wound care plans, short-term care plans, infections, residents and internal audits to separate units? It depends on how you've added. For those that are going, thank you for coming along and joining us. it depends how you've written up the level, the location and facility. In the residence detail, in the second tab of the residence detail, it's got fields there for location and facility. That's where you've got the option to put the wing and the room number. If you're putting the wing, and then when you go into the resident list or into the handover notes list, you can click on the little arrow to the right of the heading at the top of that column, and it will group them accordingly. Or you can use the filters. So if I had Kauai wing, and Tui wing, if I wrote Tui in that box at the top of that, it's just going to show me those that relate to Tui wing. Okay, so that's how you can filter that to show the separate wings and separate areas.
Gillian, we'll probably have to wrap this up soon. I'm sure everyone's quite busy, but if you do have any more questions that we haven't been able to cover off, please do email that to support. That's a shared box so everyone can answer that so it won't get missed. So if you could do that.
So I'm just writing that into the chat box there, support@agedcarecompliance.com. And once again, if there are, because this Mark's quite right, he's got to keep me to time because I just keep rabbiting on otherwise. So, because as you all know, it's a complex industry, there's a lot going on, and getting through audits is really important. So I'll come back to you on that, Katrina. Mark, can you just note that last question down? Thank you. We will have another webinar shortly. We will schedule that in relation to restraint, and once again we'll do a Q&A, just a general Q&A at the end of that, so if there are other questions, but do keep those emails coming through. One of us in the team will pick it up. If I'm out of the office, that's the joy of having the support, the shared inbox for the support. Any one of the team can pick those up and answer those. If it's something that the team feel only I can answer, or it's a bit more complex from a clinical perspective, then they forward that to me. All right. Okay. So thank you very much, everybody. I hope this has been useful for you. Yep, we're seeing some nods there, so that's great. All right. Take care. And I hope all goes well and we get past the last of these outbreaks and infections and things that we've all been dealing with. So once again, you know where to find us. We're here to help you. Think of us as an extension of your team, and we look forward to catching up with you soon.